Welcome back, and if you're new to the channel, my name is Dr. Taylor, and this is ER Medical Drama Critiques. I'm going to get right to the point. We're doing Season 1, Episode 7 of The Pit. Let's go.
Terrence, I'm Dr. Langdon. Do you go by Terrence or Terry?
Terrence,
So, what brings you in today?
I averted my ankle playing table tennis.
Averted.
Yes.
You mind if I take a look?
Are you an orthopedic surgeon?
No, I am an emergency medicine specialist.
Could I talk to an orthopedic surgeon? I'd prefer an expert in that area.
Well, I'm pretty good at ankle sprains.
How do you know it's a sprain?
Well, I'd have to examine you first, but...
Could it be a Jones fracture or a dancer's fracture?
Could be. Again, I'd have to look. Why don't I examine you, and that'll tell me...
Shouldn't you take a complete history on the present illness first?
Sounds like you're more interested in asking the questions, so...
You didn't ask if I felt the pop or a snap. You didn't ask about previous injuries. You didn't ask about weight bearing.
Why don't I get you some fresh ice?
So we see here Dr. Langdon seeing a patient that we later learn has autism. What I want viewers to see with this is how Dr. Langdon is approaching this case compared to when Dr. King approaches this case, as how she approaches it is perfect. I love it.
You need a bedpan, Myrna? Blessed.
Good sandwich?
Yeah, really good, actually.
Yeah, I can tell from all the crumbs you're getting on my workstation. We eat in the lounge, if we eat lunch at all.
I'm so sorry. I was going to grab a patient.
Maybe wash your hands first.
Yeah.
The workstation computers. So for those non-medical, generally in the ER, there's certain computers that each staff member uses. One of the ERs I work at, there's actually 8 middle computers. And these computers really face kind of different areas of the ER. And then surrounding all of those are typically your nursing or your tech computers. Now, obviously anybody can use any of the computers, but in general, the middle section is designed more for the physicians and residents. Again, at nighttime, the staff volume is a little bit lower, and in addition to that, the patient volume is a little bit lower, and so really anybody is using these computers. But the point here is that whatever desk you start at for the day, you're typically there for the entire shift, unless the computer stops working, right, and you need to switch. It takes hours to get it fixed, and you just need to go to a different computer. Or your computer's actually too close to the iHern, which is how EMS actually calls in a new patient that's coming in via EMS. And so, let's say you're getting slammed that day and you'd rather be surprised, a little bit further away from the iHern. You'd rather be surprised that, whatever that radio call is, versus listening to it go off every 10 minutes.
Too harsh?
A little.
Maybe I've gotten too soft.
Want me to find you something for lunch? Oh, you seem hangry.
I'm not.
So Dr. Robbie is almost at that breaking point, at least it seems. I said this before, the amount of cases that they're packing into one shift is just not realistic. So far, this is episode 7, and this would likely be around 3 shifts for me, at least at this point. Now, it's also not uncommon to be hangry, and nobody wants a hangry doctor, let's be honest. Some of my staff thinks it's funny, but I'll bring a MrBeast Feastables chocolate candy bar to work for those moments. If you're feeling like a hangry beast, right? You're seeing all these traumas, gunshots, stabbings, you're in one room, you're going to the next one, you're not have time to eat. If you're feeling like a hangry beast, you probably need a MrBeast chocolate bar, at least for the time being. Something to give you that boost, something to give you that energy. I figured if anybody from his team's watching, a slogan they could probably use is to satisfy that inner hangry beast, to conquer that beast of a trauma, grab a MrBeast Feastables chocolate.
You're Bradley's friends.
How do you get through the loss of a child?
Same way you get through anything. By leaning on your friends and family.
How are they doing?
Still working through it. I'll let you know when it's time to revisit the organ donation conversation.
Okay.
So these are the friends and family of Nick Bradley, the accidental fentanyl overdose. Now, this is a very sad moment seeing all these people starting to get together. My critique with this scene, and I mentioned this last episode, is with how busy this ER is. Having hallways lined up with family members and friends is not realistic. But in this case, we needed this to happen because it sets up the honor walk later, as we want that to happen in the ER and not the ICU. So we need everything, we need everybody to show up in the ER. Now, we will have this many people sometimes in certain cases, but we have a room for them in the meantime. Again, we're not talking about the honor walk yet, right? Right now, we're just talking about everybody showing up. basically all the visitors. And there's only so many people you can put in a room. There's only so many people you can put in a hallway. Outside of that, we have meeting rooms for this, like consultation rooms and things like that. So in this case, they're staying in the hallways, they're walking around, patient care is going on in these hallways. This is just not practical. This is not realistic. We don't just have this many people and visitors wandering the hallways. If you had this happen in the ICU, we have larger meeting rooms and family rooms just for this reason. You can take turns, go in and see the patient, come back out. When it comes time for the honor walk, that's different. Now you line the hallways, right? That is that's a really good ceremony. We'll talk about that a little bit later. But overall, the scene is not realistic to see an ER this busy with friends and family lining the hallways where patients come by, beds are moving, EMS has to come through. One of the hallways, you can actually see people all lining up. And again, we haven't started the honor walk yet. They're just, kind of congregating here. EMS comes through and like, hey, we have to bring the cardiac arrest in. Can you guys move out of the side, right? You shouldn't have to do that. And so that's my critique with this. And so overall, just not realistic.
Is everything okay, Dr. Langdon?
Oh, yeah. We got Dr. Google in Central 9 bombarding me with questions like my 4-year-old. I couldn't even get through a history.
Is that his chart?
Yep.
Can I see it?
Knock yourself out.
So Dr. Langdon was in the room with a patient that was autistic and didn't quite know how to handle the situation. Now, every time before I go into a patient's room and, a stable patient, I'm going to take a look at the chart and, I'm going to check, have they been here before? What's their brief medical history? Obviously, we're going to get more history, but what's in the chart right now? Is there anything in there that can help me out? Sometimes in the medical record, it actually may say autism spectrum disorder. And so you have an idea going in how you want to approach that case. Sometimes that brief look in the medical chart can make all the difference in the world, can make all the difference in the medical encounter. Is the patient visually impaired, for example? Are they hearing impaired? Maybe, they speak a different language and I'm going to need a translator going in. I've had cases before where white coat syndrome is documented in the past medical history. So in this case, it means the patient's blood pressure can increase, they can become very anxious, view vital sign abnormalities when they see a doctor, physician assistant, or nurse practitioner wearing a white coat. So what do? The white coat comes off. Again, it's how you're approaching these cases. You're analyzing the chart. You're trying to see, okay, what's the best way that I can kind of connect with my patients? As an ER doctor, I want to be able to connect with my patients. And sometimes even something very small is enough to make a huge difference. In another case I had, it was a 9-year-old. He didn't like doctors, didn't like the doctor's office, was in for ear pain. If you got remotely close, the kid would start screaming. So you say to yourself, what's the best way to approach this? This is a 9-year-old, terrified of any doctor, will not let anyone get close, does not trust any healthcare provider. You need to do an exam of that ear. You need to do your full physical exam, but you need to take a look in that ear. In this case, I actually let him look at the otoscope himself, let him hold it. I let him look in my ear. He got to inspect the otoscope, see it for himself. Shortly after, I was able to look in his ear without any issue. He was smiling, parents were smiling. He got to listen to his own heart. So it made it easier when I then listened to his heart. So overall, it turned into a great encounter. My advice for future medical students and interns and residents, try to connect with your patients. Be the difference. Be the doctor they will want to request next time. Now, obviously, it's the emergency room, so you can't just request your doctor, but be someone that they want to see. And while the ER is often a place of sadness and patients being at their lowest point, be the doctor that has a chance to bring a smile, even for a little bit. Be that doctor that has a chance to bring them that much needed smile today.
Oh, he's autistic. Did you see that in his past medical history?
It's an ankle sprain. It has nothing to do with the injury.
I could talk to him.
Great. I can see 3 other patients while you do.
So Dr. Langdon believes that autism has nothing to do with the patient's encounter, with how he approaches the patient. He literally stated that. And it appears he actually looked in the chart then, saw that it said likely, autism spectrum disorder, and just thought it's not going to have, anything to do with anything and how he approaches this. My critique with this is that he's either a third-year resident or perhaps a fourth year. We learn that he's a senior. We also learned this is a 4-year program. So he's a third year. Likely he's probably a fourth year. Now, nobody's mentioned the word chief yet, so we're not sure if he's one of the chief residents. So he may not be a chief, but either way, he's one of the senior residents. Any third or fourth year resident unless you are a horrible third or fourth year resident, is going to know that a history of autism will have everything to do with the injury in the encounter, as it changes how you approach the patient, where to stand at first, what questions you're asking. Even if he did not interact with many autistic patients over his 3 to 4 years, which again, I doubt, given how much patients that they're seeing in this trauma center, given that he's a senior resident, he would still be able to understand that it still affects so many things. It even affects the physical exam, as we need to evaluate the leg in this case. You're literally touching the ankle, the medial, the lateral malleolus, the Achilles tendon. You're checking for pulses. So for him not to know, again, he's either a third or fourth year resident, for him not to know that that history is important, that's horrible. One of my critiques, again, is that the knowledge level and the procedure level should match the year in residency. This scene actually would have made more sense if it was not Dr. Langdon that initially was seeing this patient, but maybe it was Whitaker's patient, for example, sending in a med student, as he likely would not have had as much experience in this situation. And then he sees, for example, Dr. King and asks her about the case and how he should approach it, which would then be normal, as he's, again, a medical student, first time in the emergency room, probably hasn't had, many encounters with autistic patient in the ER. So I remember that same situation as well. I was in the ER, I was a medical student, I had no idea how to approach a patient with autism. Again, a very young patient, you're like, what do I do? Do I hold them down? Do I use have the parents help me out? Like, what do I do? And it took one of the residents to explain it to me, to guide me through it. I was literally in that same situation, but I was a third year medical student. So for a third or fourth year emergency medicine resident to not know that any of this would help, that, that past medical history would help in this case, did not fit, but it's Hollywood filming. Rather, you're a 3-year or a 4-year emergency medicine residency program, each year residency, the knowledge level is going to be different. Sure, you get some rock star interns that you're like, man, this could be like a 2nd year resident. They're that good, but for the most part, there's going to be a knowledge level that changes each year. 1st year, then 2nd year, then 3rd year, then 4th year. There's a certain knowledge level, experience level as you go from medical student to intern, right? Intern to 2nd year. By the time you get your chief year, for example, if you're a chief. So, and then before you're practicing solo as an ER attending like Dr. Robbie is practicing. So there is a reason that emergency medicine is the length of the program it is, right? To prepare you to go out on your own. There's going to be that experience level. So when I evaluate these episodes, I'm also looking to see if it makes sense, the experience and knowledge level, with what year in training and what year in residency. Let's go back to episode 1 briefly, when Dr. Collins actually asked how the rhabdomyolysis and hyperkalemia even happened. Like, she had no clue. Let's go ahead and watch that clip.
Charged and clear.
Back in sinus. Otis?
The monitor, wide QRS and peak T waves, hyperkalemia.
Get that.
Intense exercise caused muscle breakdown, rhabdomyolysis, knocked out his kidneys. Now he's not clearing potassium. I bet it's over 7.5.
So again, she's a senior resident. She's a 3rd or 4th year resident. She should already know this. This makes no sense. Again, the degree of emergency medicine education should correlate with the case itself. You're not going to see a senior resident say, what's a complete heart block? Or have a senior resident say, how do you put in a chest tube? Earlier, Dr. Langdon, again, being a 3rd or 4th year, heard Dr. Robbie say he was going to do a retrograde intubation. Dr. Langdon mentioned he never saw a retrograde intubation before, which is fine. It is rare to do, but he should have at least seen it or heard it before, especially at a trauma center like this. At least watched it in, like, he saw it in a book or watched it in, some kind of YouTube video, something. So again, it makes no sense at this level of training. It would have made more sense, again, coming from a 1st or 2nd year resident. I'm sure there are a few other things as well throughout the first 7 episodes that did not quite correlate with the degree of training, but those are some of the specific ones that I remember, and some of the ones I've talked about before. Very minor critiques overall. Again, these are just things that stand out like a sore thumb, but it looks great for Hollywood.
Overheard a nurse saying they found rats back there.
What?
Yeah. Pest control takes priority. Guess you got bumped again.
Can somebody help me, please? We need a wheelchair here. What happened? I was on my way home and I saw her in the road. She was in and out of the intersection, yelling at cars and people.
So to recap, this is a patient that was coming in, observed to be running around the intersection and yelling at cars, and was brought in by a roommate. So I had cases like this before that come in after being hit by a truck, a car, a semi. So for the roommate to recognize her, to stop, to pick her up before something potentially even worse happens was absolutely awesome. I love this. This could have easily been a way different situation if she kept wandering around the intersection and then got hit by a car or something like that.
What's her name? Nandi. She's my roommate. Did she get hit? Her knees are all scraped up. No, she tripped while I was pulling her out of traffic. Does she have a psychiatric condition? Not that I know of. Just get her to bed. You're okay. Let me go!
So my critique with this is that she's asking all these questions in the waiting room and everyone nearby can hear. There's no reason all these questions need answered in the waiting room. These can be answered in the patient's emergency room. Like, bring them back in a room. The resident even asked if she had a psychiatric history. Even if she does, it does not change anything at all right now. Get that patient back into a room and finish your questions. Let's say the friend says, yes, she does. She has a psychiatric history. In fact, she has bipolar. Congrats. Now, everybody nearby knows this, and it did not change any of your management. The key thing right here is right now. If you know this history, does it change right now? And the answer to that is absolutely not. Will knowing this patient has bipolar change anything right now? No. Get them back into the room. It's another maybe 2 minutes tops to get them into a room. Now, this patient does not have bipolar disorder, as we learned, but I briefly wanted to touch on this topic as this does happen. Certain things you do and you do not do in the waiting room. On an earlier episode, the nurse comes out stating Tylenol and then names the patient. That was unnecessary and that was not appropriate. I forget which episode that was, but literally comes out into the waiting room, calls the patient's name and saying they have Tylenol. Calling the patient's name, that's fine, right? Massive waiting room. When you identify them, you're also looking at the identifier on the wrist to confirm, and then you're mentioning the medication you have for them. You're not just announcing the medication overhead for everybody to be aware. On an extreme example, it'd be like someone coming out and being like, so-and-so, I have your Vagisil cream. That's an extreme example, but it's the same concept as this does happen, but it should not happen. In our situation, the only thing that really changes our management right now, for example, given this patient's talking, the only thing that changes our management right now is if this was a trauma, or if she had signs that she was actually hit by a car before this happened and was still wandering around confused because she's in shock, and then a friend brings her in at that point. So knowing that would potentially change our management, but knowing the psychiatric history does not change the management at all right now. It's just not realistic to start asking all these questions in this situation, as it did not change our management, but it looked great for television to ask them. Just not realistic.
Hi, Terrence. I'm Dr. King.
Hello.
Dr. Langdon is with another patient right now, so I'm going to finish taking your history. Is that okay?
Sure.
Okay. It's a little bright in here. Oh, that's... Sorry, the ER can be very noisy.
I agree.
So I heard that you might have sprained your ankle playing table tennis?
I averted it.
Yeah? What is your biggest concern today, Terrence? What worries you the most about your the pain in your ankle?
What worries me? Do you mean right now in this moment?
Right now.
I'm worried I won't be able to play table tennis if it's a bad injury. There's a tournament in 6 weeks and I already registered. It's my first tournament.
Wow, that's a big deal.
Yes. The championship is hosted by the South Park Table Tennis Club. 9 players have USATT ratings over 2,000. 1,400 is considered average. 2,000 is a master player. My goal is to get a rating over 2,000.
So as we continue this part of the critique, I again want you to take a look specifically here at the body language. How Dr. King is going about this case, what she is doing, as is very technical and with a purpose and absolutely brilliant. And then compare it to how Dr. Langdon approached this case as well. So Dr. King knocks on the door, waits a second, and then enters. Does not immediately approach the patient and introduces herself first. The ER is noisy and loud, so she proceeds to then shut the door. She's making sure to not get too close too fast. She is taking away that noise. She's asking permission to take the history, really making him a part of this case. When she states a little bright in here, she is likely stating exactly what he's thinking, and it's already starting to build that trust level. She turns down the lights, so now we have less noise and less brightness in what overall is an extremely busy ER. She is aware that he is likely concerned about the noise in the ER, and when she states it and he agrees, that trust continues to develop. She is truly showing an interest in this patient and asking his biggest concern. Amazing. When she asks, what worries him the most? What worries you the most? It is really an open-ended question that we're asking that allows the patient to express himself or herself. He's looking at her and he opens up. We find out that he's worried he won't be able to play in table tennis tournament, if it's a bad injury. She mentions the table tennis tournament is a big deal, and he responds with yes. This entire scene that she is connecting with the patient and building trust. Like what I mentioned before, you want to connect with your patients. He eventually opens up completely and starts explaining the tournament details. You can already notice the difference between Dr. King's approach and Dr. Langdon's approach.
Well, let's get you to that tournament then. So Terrence, would you walk around the room for me, please? I'll be able to tell a lot more about your injury.
Hurts a little. How painful? On a scale from 1 to 10, 10's the worst.
The worst? The worst I've ever felt, or the worst that a human being can experience?
A little pain is a great answer, Terrence. Thank you. Well, based on your walking around, I don't think it's a serious injury. You know what? There's actually something I want to show you. I'll be right back.
So of course, Dr. Langdon comes in the room and just ruins the vibe. The facial expression at that point on that patient says it all. Even though Dr. Langdon is back, the door is now open, the noise is higher. There was enough trust built within that short period of time when Dr. King was in the room that when Dr. King asked him to walk around the room, he does, right? There wasn't much hesitation there because that trust has been built. He trusts her enough at this point and knows based on what she has said that his interest is what she is concerned about the most. So knowing that her goal is to get him back to this tournament, right? That tournament's the most important thing that he has right now, that he wants right now. And to know that that's her first priority, he gets up and just walks. I personally would have did an x-ray first before having him walk around unless she was evaluating the Ottawa ankle rules, which I'm not going to get into in this critique, but I'll put that up on the screen for you so you can feel free to review those. But I'll let you look that up. But overall, just a terrific scene.
What was that?
It's olanzapine, 10 milligrams.
Do you know any of her medical history?
No, we've only known each other for a few months. We're both influencers. We met online. I thought it would be a good idea to live together.
When did she start behaving differently?
About a month ago. She's been up at all hours talking to herself nonstop. I think she's suicidal.
Any drug use?
No, I don't think so.
Spotty, Whitaker, see if you can do the exam.
Can you look at the light?
No, what was that?
Okay. Open your mouth.
No, it's not real. Where am I?
How do you even do an exam with a patient like this?
The furniture's changed.
Observe her. Wait for her to look at you or open her mouth and get a quick look. Make sure she moves her arms and legs equally.
This is just to monitor your heart.
All right, we might need to wait until after the meds kick in.
Perfect, Dr. Robbie. This is what I was waiting for. Let's wait for the meds to kick in. Now, they gave 10 milligrams of olanzapine or Zyprexa. That's fine. Love it. Personally, I would have done Versed IM, so Versed intramuscular, but Zyprexa is fine as well. Personal preference. Zyprexa is a second-generation antipsychotic. Tons of uses. Acute agitation that we see, for example, with schizophrenia, with bipolar. It could be used for a multitude of other things, including, agitation, depending on the situation and the cause. Once the patient is more calm, it's going to be easier to get that patient on a cardiac monitor to do the rest of the detailed physical exam. We need a good exam here, right? Is this drugs? Is this toxins? Is this metabolic? Is this psych? The list goes on, and we need a good exam.
Is it
Anybody?
the same place?
Okay, differential diagnosis.
Schizophrenia, first psychotic break. She's in the right age range.
Yeah, what else?
Drugs also common in this age group.
Common in all age groups. What else?
Not just recreational drugs, could also be toxicity to medications. Don't jump to conclusions. Think big categories and then specifics.
Metabolic, hyper or hyponatremia, calcium, hepatic encephalopathy.
Endocrine, hyperthyroid, infectious encephalitis.
Those are all possibilities. Okay, let's work her up medically, see if we can clear.
Chem panel, CBC, TSH and T4, drug screen, and HCG.
Yep, keep me posted. If it's all negative, then we leave her to psych.
Solid differential, no critiques here. I just want to, kind of review this as there's some teaching points we can really get out of this case. So you can start broad and then get more specific. I've said this before, the more you don't know, the more you need to ask. And if you cannot ask or get a reliable answer, you're then getting more blood work to narrow that down further. Take, for example, an actual case I had. Someone comes in unresponsive, intubated, last seen normal at least 2 days ago. You cannot get any history from the patient because they're unresponsive and they're intubated on a ventilator. Let's make it harder. There's no info from family. There's no family present. You can't get a hold of anybody. All right. EMS was called by a cleaning crew at a motel that found the patient unresponsive. There's no obvious bottles on scene that EMS reported. There was no signs of trauma on your physical exam. You literally had nothing. You had the initial EMS set of vitals and kind of what they saw on scene. And then you have your set of vitals in your physical exam. At this point, you're playing detective. The more you don't know, the more you need to investigate. In this case, the patient was found to have jaundice, so they're yellow, scleral icterus. The ammonia was 150. Patient had a significant transaminitis, and the Tylenol level was well above the toxic dose, toxic line, even at 2 days, at least 2 days after. So still very high. The patient was in liver failure secondary to a severe Tylenol overdose. Now, were we told the patient took Tylenol? Nope. We relied on the physical exam in the labs to hopefully go from a broad differential to narrow that down to a small differential. So in this case, again, you're doing more of kind of an altered mental status workup. So it's a CBC, it's a complete metabolic panel, it's an ammonia, we're checking pregnancy. You can consider, a TSH as well with a reflux, so we're checking thyroid, potentially magnesium as well. You're doing urine studies, drug studies, and alcohol level. You're trying to see if we can narrow down the differential even further. Now, I would also add on an aspirin level, a Tylenol level, and an EKG. Now, she never mentioned aspirin and Tylenol levels here, but that's pretty standard when, we do these toxicology workups, if we call tox or discuss the case with them. Again, when you have that broad differential where you're considering a potential, medication, it's a younger patient, they're altered, it's pretty standard to get Tylenol and aspirin. So that's my only critique with this part of the scene is I would have added that on there. This early on, again, we're doing a medical workup, but also a tox workup at the same time. For the EKG, do we have a prolonged QRS? Do we have a prolonged QTC that we can see with certain drugs and medications? Is the QTC prolonged? Is the MAG abnormal? Did she ingest something here? So I love the labs the resident wants to do. I would just add a few more onto that list. Now, I'm not going to be following this case all the way through for the time because I want to focus on some of the larger items. But basically, the resident adds on a mercury lab test and treats the patient when the level comes back elevated. That part is just not accurate, not realistic at all. Now, the lab test itself, typically it's part of the heavy metals panel, can take days to come back. Now, some labs will call it something different, but in general, it's a panel of various heavy metals, mercury being one of them. Now, I called one of the labs at one of the hospitals I worked at. I called another lab at one of the hospitals because I was curious myself how fast these come back because I've actually never ordered one, all right? And these are all send-out tests, not even done in the hospital. And these can take 1 to 3 days to come back. What's interesting is a lot of hospitals actually have the same protocol. The specimen is either sent to what's called the ARUP laboratories in Utah or Mayo Clinic, depending on which test. Now, there's a few other centers that will take the heavy metal testing and they'll do that testing, but these are two very common ones. Again, ARUP laboratories in Utah or Mayo Clinic, depending on which test. Every hospital is going to have a location it sends the specimen to. In reality, we would actually admit this patient and the medical team would take over. But again, it looks great for medical dramas for the resident to order a test that does not come back in the ER, is a send-out test, and all of a sudden it comes back rapidly. Haha, yeah, right, and not realistic. Now, is this a special, TV medical drama that has a, rapid blood level test that comes back for mercury? Maybe. Maybe it's a different test that I'm not aware of, but the majority of these are send-outs. The majority of these go to other places to analyze it, and it takes 1 to 3 days to come back. So overall, just not realistic, but we want this scene, we want this to happen. So we have to give that appearance that it's coming back right away. It's just not realistic.
Sometimes this tendon called peroneus brevis can pull off a piece of this bone, the fifth metatarsal.
That's the dancer's fracture, right?
Exactly. You most likely have a second-degree ankle sprain. The x-ray will tell us everything.
Amazing. Showing him the anatomy, explaining the sprain. The only critique here is that she states the x-ray will show us everything. No, it won't, and not even close. It'll show us broken bone or not broken bone. It's not going to show you ligaments. It's not going to show you tendons. Again, we're talking about an x-ray. Now, depending on the situation, we can see findings on an x-ray that can be suggestive of an underlying ligament or tendon issue, but we can't actually see that actual injury. And I'll explain this to patients numerous times, the difference between an x-ray or a CAT scan or an MRI and what we expect to see with each one. Take, for example, an x-ray. We do that, patients got, they got ankle pain or leg pain, they had a fall, they heard a pop, something related. Playing basketball, they heard a pop. So the x-ray shows an obliterated Kager's triangle or obliterated Kager's fat pad. That can be seen with a ruptured Achilles tendon. We can't actually see the ruptured Achilles tendon, but you can see that area that's now obliterated. So I'm going to put that x-ray on the screen for you. I'm going to put a normal one, and I'm going to put the abnormal x-ray next to it. Now, obviously, there's other physical exam findings. For example, then, a patient has an obliterated Kager's triangle or Kager's fat pad, we're going to start seeing absent plantar flexion. Sometimes we'll do a linear transducer or an ultrasound just in the back leg, and you can actually see on ultrasound that rupture itself. But this is a patient that typically is going to get placed in a splint itself. They're going to get splinted in plantar flexion, crutches, given ortho for follow-up, and then they're going to get surgery. Now, again, I'm going to put a normal x-ray on the screen for you to kind of show you what that looks like. And then again, kind of comparing it to a torn Achilles. Now realize the x-ray is not going to show us everything. In some cases, no fracture is seen on the initial x-ray. Let's say a patient comes in, they had a fall, an inverted ankle injury, playing sports, something related. And the physical exam shows some soft tissue swelling. The x-ray, a little bit of soft tissue swelling, but no obvious fracture. We splint them, we give them ortho for follow-up. Hey, if there's continued pain, in the next 7 to 10 days, we recommend repeat imaging to rule out any underlying occult fracture that was not visible on the initial x-ray because of the swelling. I've had a few patients that they get that repeat x-ray and there's a subtle hairline that was not caught on the initial x-ray because of the swelling. So overall, a small critique, but the entire situation is still awesome. I love it. Just a few small details I just wanted to correct. Again, the only reason I can go in depth this much in this entire season is because of how accurate and realistic the season already is. If this was Grey's Anatomy, The Good Doctor, The Resident, even Chicago Med, and a few other medical dramas, where at baseline, it's not realistic and you can just pick it apart like crazy. If you take one of these medical dramas that at baseline is not realistic, sure, it's got its parts where it's got its episodes where a little bit more realistic, or that's a little bit more accurate. But if it's a baseline not realistic, I would not even bother with small details. It would just take too much time. That just goes to show you how good this medical drama is and how accurate and realistic it already is.
Okay. I'll put the orders in.
How'd you do that?
Do what?
Talk to him.
I listened?
Funny. No, you unlocked something. I wasn't getting anywhere with them.
Oh, my sister is on the spectrum, and the ER can be a very, very overwhelming place for autistic people. So I don't know, it just takes a different approach.
You and your sister close?
Yeah, we're best friends. There's this one time we were on the swing.
I gotta get the head.
And then, yeah.
Let me know when the x-rays are back.
Huh?
Even if he doesn't have a family member that's autistic, does not mean you have not learned how to interact with a patient that is autistic. Again, Dr. Langdon is a 3rd or 4th year resident. Most likely he's probably a 4th year. Again, we know it's a 4-year program. He's a senior. He likely would have encountered this prior a few times, at least a few times. I had this encounter numerous times as a resident. I can't even count how many times I've had this. Again, unless he was not a 3rd or 4th year resident, not a good doctor, or perhaps a Hollywood doctor, he should know that the patient's history changes everything in this case in terms of how you approach this patient. As with all my videos, given the length, I try to put some comments in there. So we're going to take a break here and go through some comments I received from the video from the episode 6 review. So let's go through these now. Again, I'm going to put these on the screen for you. The amount of ads on this is insane, my dude. Yeah, so the last episode, the last critique I did was an hour and 47 minutes. So YouTube puts all the ads in there. My average watch time is approaching 30 minutes on average. So people are literally sitting down 30 minutes straight watching that. That is insane. The amount of viewing time with that is pretty crazy. And then, of course, people obviously log in and you're like, all right, I'll catch the next 30 minutes a little bit later, or I'll catch the next 30 minutes, later. So YouTube is putting a lot of ads in. I don't know how many ads they're putting in, but they do that one. Next one. You're absolutely correct, Dr. Taylor, about this scene with a student who is brain dead. That patient would have been out of the ER hours ago. As someone who started a neuro step down before working in primary medical ICU, so many memories of these terrible circumstances. Cold calorics, nuke med brain scans, it's soul crushing. ER does not have the time for all of that. And quite honestly, family members of these types of patients need attention, sensitivity, and the ER is just too busy to provide the medical and emotional support for these sad neuro cases. And again, this was more referencing along the lines of how long this patient was in the ER for. And at that point, they should have been in the ICU, and ICU would have been managing this versus the ER doc ordering all these different tests and not consulting any specialist. Next one, great videos, very informative. And as someone who's planning to go to med school, this is great stuff. Awesome. I'm glad you enjoyed the channel. Your reviews of this show are by far the best on YouTube. Extremely informative and entertaining at the same time, so thank you for that. Please don't stop making these videos, considering becoming an NP or a nurse practitioner. And these videos are super inspiring. I love it. Thank you. So another one, yes, I need a collab from a bunch of ER workers. This was in relation to, a comment I had made about, if we can get like an ER doc, an ER nurse, you get a bunch of people to collaborate together to review an episode, that would just be awesome, because then you get a different perspective from everybody. So I love that. And another one states, while I understand you're wanting to make it clear how things should happen in the real world, the reason you don't see every member of staff there that would be there in a normal hospital is because of the casting budget limits for the overall per episode budget. So this was actually talking about how we never see respiratory, how we never see, nurse practitioner, physician assistant, how we don't see a portable x-ray machine. And someone had said, well, maybe it's a budget issue. And that I'm going to go ahead and deny that. I don't think that's the issue. Take, for example, you can actually mention portable x-ray going by, or you see the portable x-ray going by just in one clip, right? I've already reviewed, again, the next few episodes, and we do see for the first time ever a portable x-ray machine. So I know it's not the budget issue. Another example is, an ER this size, you're going to have nurse practitioners, you're going to have physician assistants, you're going to have that. And again, we don't necessarily have to focus on that for too long. Like, you can have one of the residents or one of the attendings briefly talking with a physician assistant or a nurse practitioner. We do that all the time. I'm going to do that tomorrow on shift. I'm going to do that every day that I have shift. That's going to happen. And so briefly talking to them and would just add a little bit to that. Or probably another one. We know that the next season is going to happen in July, where all the new interns are starting, right? Some of those interns, their first month is going to be in the ICU. That's exactly where my first month was. And so it could be as simple as Dr. Robbie is in the ER with some of the ER residents, the ICU attendings coming down. It could be along the lines of, hey, John, I see you got the new interns. Yeah, I got the new ICU interns today. And you watch literally ICU attending with the ICU interns all coming behind him. And again, that's just less than a minute. And it really gives that dynamic. Hey, there's the ICU attending. It's kind of a different perspective. And so I think it's important for this. All right, let's get back to the critique.
Hey, need a hand with the STEMI?
We're all set. Whitaker, you're with me. Trauma 2.
Chest pain with diaphoresis, anterior STEMI and triage.
So this patient came through triage and was diagnosed with a STEMI. Now, this goes back to the triage process itself. So his wait time, likely he had just walked to the front desk, mentioned chest pain. They did an EKG and triage. It showed anterior STEMI, and then the patient was immediately brought back. So an anterior STEMI, or what we call an anterior wall MI, usually results from an occlusion of the left anterior descending, or LAD. And so an anterior MI carries the poorest prognosis of all infarctions, secondary to the large area of myocardium infarct size. Now, talking about EKG patterns, Welland syndrome, De Winter T waves are a different discussion when talking about the LAD. But I'll put an EKG in the screen for you demonstrating an anterior wall MI, realizing The appearance can change depending on where we're at in the symptoms. Did the chest pain just start? Has it been going on for a while, right? Is this a hyperacute anteroseptal STEMI? Is this a hyperacute anterior STEMI? Is this an extensive anterolateral STEMI? Or is this an extensive anterior STEMI? In the scope of things, it is a STEMI and it needs intervention.
I'm Dr. Langdon. This is Dr. Robbie.
Harvey Ting.
You're having a heart attack, sir.
I figured.
You ever had one before? How much pain?
Like an outlet's on my chest. Are you taking any medications? Metformin and rosuvastatin. 170 over 92 at triage.
324 chewable aspirin, sublingual nitro, Q5 times 3.
Cath lab is standing by and ready.
Harvey, if we get you up to cardiology, they can open your blocked artery. We can stop this heart attack.
Anyone got a score for the Pirates game?
They're up by 2 at the bottom of the first. Concussion hit Apple Taco.
Clutch.
Is anybody we can call?
My wife died a year ago. I guess today's the day I'll be joining her.
Oh, I appreciate that sentiment, but that is not part of our plan.
No murmurs, radio pulses are symmetric.
VFib. Whitaker, chest compressions, charge you 200.
Now here he went into ventricular fibrillation, or what we call VFib. Now we have two shockable rhythms, either VFib or pulseless VTAC. What you end up with VFib is that you get a rapid and irregular electrical activity that basically renders the ventricles unable to contract in a synchronized manner, resulting in the immediate loss of cardiac output. Unless intervention happens, this rhythm is fatal.
Best way to face your
I
fears.
can think of better ways.
Let's back him on 100%. Set up for intubation.
Charged and clear.
Still VFib. Resume compressions. Let's get him on the Lucas.
So I'm not going to dwell on this too much, but this is TP CPR, television princess CPR. However, I will say he's above the patient here and his arms are extended, which is terrific. Just not the actual CPR. This is TP CPR.
Set 200 joules, asynchronous plus charge.
Pause compressions.
Still VFib.
No pulse. Clear?
Clear.
Got your cue, Whitaker.
Shit.
So here we hear the words asynchronized. So asynchronized or unsynchronized cardioversion is basically a high energy shock that is delivered as soon as the shock button is pushed on the defibrillator. This means that the shock may fall randomly anywhere within the cardiac cycle. Now, we use this when there's no coordinated intrinsic electrical activity in the heart, as is the case with pulseless VTAC or VFib. Now, this is in contrast to synchronized cardioversion that uses a lower energy shock, that uses a sensor to deliver electricity that is synchronized with a peak of the QRS complex that we use, for example, like SVT, AFib, VTAC with a pulse, just to name a few. If you recall, episode 1 dealt with, it was either SVT or AFib, I forget which one offhand, but great scene of a synchronized cardioversion. I didn't critique it because it was just awesome. So when the sync option is engaged on a defibrillator and the shock button pushed, there's going to be a delay in the shock. During this delay, the machine reads and synchronizes with the patient's ECG rhythm. This occurs so that the shock can be delivered with or just after the peak of the R wave in the patient's QRS complex. So in the case of this patient, the patient's rhythm is lethal, right? If we don't intervene on this is a lethal rhythm. So they're going to be dead if we don't intervene on this. So we want a high energy shock that is delivered as soon as the shock button is pushed, especially in the case of no coordinated intrinsic electrical activity in the heart.
No change. Epi and amio, please.
He's not coming back, is he?
We still got a ways to go.
What have Epi's in?
Double sequential defibrillation next.
Worth a shot. I'll put in an art line.
Right sternal border, apex.
The theory is that the first shock lowers the defib threshold, so that the second shock has a better chance of converting into fibrillating myocytes.
Mr. Wallace?
Double sequential defibrillation. So far in this series, we are hit with so many procedures and already had so many big things happening. So why not talk about double sequential defibrillation, right? Why not do this? At this point, the patient is reportedly in refractory VFib. Or is he? He has been shocked now twice. Now, we hear the amiodarone is being given. If I'm remotely considering double sequential defibrillation, personally, I've done it once. Another one of my colleagues has done it quite a few times. So if I'm remotely considering this, right, if I'm remotely considering double sequential defibrillation, it's typically not until after the third shock And the key with this double sequential is that the appropriate meds have already been given, right? A patient does not just come in, I shock one time, and then all of a sudden I do double sequential defibrillation. That makes no sense. In this clip, they mention that amiodarone is being given. Now they're setting up for double sequential. Now, I would have given amio and shocked a third time, and if nothing yet, did the double sequential defibrillation. So as you're probably aware, I try to keep things literature-based and make it my priority to stay up to date in the most recent guidelines, and I'll put sources and references on the screen when I can, just so that my audience is kind of fully aware and you're able to kind of do some research on your own. This patient underwent double sequential defibrillation for reported refractory VFib. The question is this technically refractory VFib, right? A patient doesn't just come into the ER, boom, they're in refractory VFib, and we shock them with immediate double sequential defibrillation. There's a strategy to this. At what point is this refractory VFib? And at what point are we doing double sequential defibrillation? These are very important questions. Now, for this answer, I turn to an article published in the New England Journal of Medicine. This is one of the foremost authorities on medical literature within the educational community. The article is titled Defibrillation Strategies for Refractory VFib. They define refractory VFib as, in quotes, the initial presenting rhythm of VFib or pulseless V-tach that was still present after 3 consecutive rhythm analysis and standard defibrillations, 3 defibrillations, all right? Multiple other references will also state at least 3 or more. In another article published in the National Library of Medicine and Intensive Care Medicine Journal entitled Double Sequential External Defibrillation for Refractory VFib, they state in quotes, shock should be provided after the 3rd failed standard defibrillation. So in our patient, he was only shocked 2 times, and then they were setting up and they were doing double sequential defibrillation after 2 failed shocks instead of 3. But again, this is a TV medical drama. We can't let this go on too long before doing double sequential defibrillation. Again, very small detail, but I wanted to mention this. I want to give you, the sources and the references and just kind of clarify a few different things. So what is double sequential defibrillation? Per the New England Journal of Medicine, double sequential external defibrillation is a technique of providing rapid sequential shocks from 2 defibrillators with defibrillation pads placed in 2 different planes, either anterior lateral or anterior posterior. This has been studied for decades in the electrophysiology laboratory for use in patients with refractory atrial or ventricular fibrillation. So you're going to notice in the clip that they place pads in 2 different spots as well. So next up, we're actually going to look at, can the double defibrillation be simultaneous or sequential? And for this, we actually turn to the American College of Emergency Physicians, or ACEP, in critical care medicine when they talk about double sequential external defibrillation. In quotes, can either be simultaneous or sequential depending on the duration of the defibrillation potential and the intershock interval between the 2 defibrillator shocks. There is currently no evidence to suggest sequential or simultaneous is more effective. Now, there are 3 main hypothesized theories as to why this type of defibrillation is effective. Now, I'm not going to go into detail on these. I'm only informing viewers of the 3 most common hypothesized theories as to why something like this can be effective. Now, obviously in our patient, the goal was not to make it effective. Otherwise, we wouldn't be activating the ECMO team that follows, and I really look forward to talking about that.
All right, Whitaker, if he's pulseless, we clear it and then shock. I go first, you hit it as fast as you can.
I got it.
Charging both to 200.
Charged.
Pause compressions. No pulse on the A line. Clear for the 1-2 punch.
Clear.
Resuming compressions. How's our Hail Mary?
We got one more.
So the first theory is referred to as the more power theory. Several studies have shown that the higher energy has improved success on subsequent defibrillation. This is why it's often termed double simultaneous defibrillation. So lack of real-time measuring devices and subsequent delay in human response times makes it difficult to consistently perform true simultaneous defibrillation in the clinical setting. So several studies have also shown safety in patients receiving up to 720 joules of monophasic energy in this setting. So in this clip, they did not do simultaneous, right? It wasn't the same time. They did shock. So they did one after the other. And likely that had the human delay in response time that can make it difficult to perform that true simultaneous defibrillation. The next theory is called the setting up theory. So in this theory, it's suggested that the first shock actually lowers the defibrillation threshold, thereby increasing the second shock's success in converting any of the remaining fibrillating myocytes. So this is actually where it gets its second name, double sequential defibrillation. It's also the more likely method of administering it in the clinical setting, which is perfect because this is what happened on the TV show, and Dr. Robbie mentions this as well. So I love this. Whoever was behind the script for this scene knew about the setting up theory, knew about this part of it, incorporated it in it, let the audience be aware of it, showing why this can be potentially effective, and I love it. Super kudos on this one. So the last theory is called the multiple vector theory. This theory basically suggests that providing more pads just increases the number of vectors that electricity can use to reach the myocardium. Overall, I feel that double sequential defibrillation could be its own lecture, but for the Pitt to even consider this, to even cover this in detail like this, and even talk about briefly one of the theories, that's impressive. And to go through this, mad kudos. I did not expect this. I was expecting something, just a double sequential defibrillation and move on. But the fact that they actually talked about the setting up theory, of course, obviously it failed and we did ECMO, but to even mention that theory is impressive. I love it. Super realistic. Love it.